First of all, I'd like to thank Dr. Mohan and team for giving me opportunity to talk about ACLF in this forum. So today I'll be talking about ACLF, overview of ACLF. Since ACLF is a vast and then controversial topic, various associations, liver associations have different opinion regarding ACLF. I'd like to just summarize the concept of ACLF along with the management regarding ACLF. So any insult occurring on a liver pre-existing chronic liver disease is ACLF. So Asian Pacific Association for the Study of the Liver, APASL, was the first multidisciplinary group dedicated to ACLF who gave the first consensus definition. So acute hepatic insult manifests as jaundice and coagulopathy, which is complicated within 4 weeks by ascites or encephalopathy. That is hepatic insult that is occurring on the pre-existing diagnosed or undiagnosed chronic liver disease. So we classify this group of patients who undergo these kind of injury as ACLF. So ACLF is any acute hepatic insult. Jaundice, it should be bilirubin should be more than equal to 5, and coagulopathy represented by INR more than equal to 1.5 or PT activity less than 40%, and complicated within 4 weeks by clinical ascites or encephalopathy in a patient who may not be diagnosed, who may not be a diagnosed chronic liver disease. It can be diagnosed or undiagnosed, but the patient has chronic liver disease or cirrhosis. And then later they modified it, the definition they modified it, and they defined as it's associated with high 28-day or one month mortality. So various classification of ACLF is there. So I would like to classify this, which was given by EASL in 2018 European Association. So they described ACLF as 1, 2, 3 according to the number of organ failures present after the ACLF sets in. So they found out that as the ACLF, there is more organ failure in ACLF, the mortality is significantly rises from no ACLF to grade 3 ACLF, and in grade 3 ACLF 90-day mortality reaches up to 78%. So this is the pathophysiological stages of cirrhosis and ACLF. So whenever there is some precipitating factor like virus, drug, alcohol, ischemia, surgery, infection, so it occurs in pre-existing chronic liver disease, compensated cirrhosis, or even in a decompensated cirrhosis. So they have defined it as type A, type B, and type C ACLF. And then whenever there is precipitants like these occurring in the presence of chronic liver disease, then hepatic and extrahepatic organ failure sets in. So up to 40 and 50% of the cases of ACLF may not have identifiable trigger factor. So there is a golden window period of approximately 7 days when the intervention for the ACLF is the best. So whenever there is acute hepatic insult and then we intervene these patients within this golden window period, chances of reversal of ACLF is usually high. So an excessive pro-inflammatory response, formation of microthrombus, capillary leak, mitochondrial dysfunction are the primary things which are occurring in ACLF. And on the other hand, excessive anti-inflammatory phase increases the risk of infection, which is the most common complication of ACLF and most dreadful complication of ACLF. So this is the sequence of what happens in ACLF. Whenever there is a previously diagnosed or undiagnosed chronic liver disease, their injury occurs, and then there is the inflammation and finally leads to organ failure. And in these various stages, we can assess these patients, and then again we have to intervene accordingly. So there are various scores for ACLF to predict the disease severity. So previously the EASL European guidelines have modified SOFA score into CLIF SOFA, and then again CLIF C ACLF, CLIF C organ failure score. But the association of Asian Association, I mean APASL, has graded this ACLF into grade 1, 2, and 3, and they have included total bilirubin, He, INR, lactate, and creatinine, and then they have given this scoring system. And then as the score is higher or is more than 11, the mortality reaches up to 85.9%. 28-day mortality reaches up to 85.9%. So the ARC score, which was recently published, was significantly more sensitive in comparison to previous score like Apache, SOFA, and then obvious CTP, MELD, and then CLIF-C ACLF score. So they found out that the ARC score was better in predicting mortality in comparison to other scores. So there are various infectious and non-infectious precipitating events occurring in ACLF. So the common infectious etiologies are hepatotropic and non-hepatotropic viruses, and then also reactivation of hepatitis B. And the most common non-infectious precipitating event is alcohol and use of hepatotoxic drugs, herbs, and then sometimes flare of autoimmune hepatitis, paracentesis, surgical intervention, and variceal bleed. So the management of ACLF is mainly supportive and with intensive monitoring and then support of failing organs. So treatment of underlying precipitating factors should be done first, followed by management of organ failures, bridging therapy, and then finally liver transplant is the ultimate treatment. So we should use antibiotics as like treatment for precipitating factors for bacterial infections, antifungals whenever it's indicated, albumin while in SBP, corticosteroids, and hepatitis B antiviral for every flare. So managing of organ failure is the key, main important challenging part of this ACLF. So managing infections, HE, ascites, renal impairment, coagulation profile, and obviously varices in ACLF are the main primary thing that we should be doing. So whenever there is a renal impairment in case of ACLF, first we have to differentiate it into structure or functional AKI. So if there is a functional AKI is something which is reversible. So we should access the 6 hour, like IBC, 6 hourly IBC assessment, monitoring of mean arterial pressure, urine output, creatinine, and if the AKI is persistent or progression, look for IBC collapsibility. And if it is more than 40%, start with albumin infusion, and then at 12 hours use terlipressin, and then if there is no IBC collapsibility, then we can straight go for terlipressin as a mode to increase the mean arterial pressure and then renal perfusion. And then accordingly, if there is a good response, then we de-escalate the dose, and then if there is no response, we escalate the dose. So whenever there is HE in ACLF, as a regular management of HE, lactulose is the main primary treatment, mainstay of treatment, lactulose, followed by like Lola, aspartate, rifaximin, sometimes plasmapheresis, and then albumin dialysis may be necessary. So whenever patient has higher grade of hepatic encephalopathy in ACLF, and then we should prioritize them for early liver transplantation. So this, whenever almost 1/3 of the patient with ACLF needs paracentesis. So whenever we do paracentesis, the chances of PICD in ACLF, the chances of PICD occurring in ACLF is more than regular decompensated liver cirrhosis. So whenever there is, we plan for large volume paracentesis, we should try to avoid, and then make it a modest volume paracentesis, that is less than 5 liters. And whenever and then albumin infusion while doing paracentesis is very much necessary. So point of ultrasound is in the management of ACLF finds out other patients. Ultrasound can diagnose hepatic hydrothorax, and cardiac ultrasound or echocardiography can diagnose cirrhotic cardiomyopathy. Hemodynamic assessment can be done. Renal ultrasound can be done to differentiate pre-renal, renal or post-renal causes, and then procedural guidance can be done with the point of care ultrasound. Also very important in case of managing ACLF to find out the complications of cirrhosis, the coexisting complication of the cirrhosis or ACLF. So there are two artificial liver support system, molecular Mars and then Prometheus. So they help to achieve detoxification functions and to remove inflammatory mediators in patients with ACLF. So these are usually used as a bridging therapy in case of ACLF until the patient are eligible or patient is ready for liver transplantation. So plasma exchange is another important thing we can do in ACLF, which decreases pro-inflammatory cytokines, dams endotoxins, bilirubin, lactate, ammonia, and ultimately the patient. This helps for the patient to like decrease the mortality and then go for liver transplantation. So the plasma exchange has, in a meta-analysis, the plasma exchange was seen better in comparison to the standard medical therapy, and then it favors in decreasing mortality, morbidity, and ultimately helps the patient go to liver transplantation. So immunomodulatory treatment can be given GCSF in the case of ACLF. So it improved GCSF, improved liver function and SOFA scores, and prevented the occurrence of hepatorenal syndrome, HE, and sepsis. So it mobilizes bone marrow stem cells and the proliferation of hepatic progenitor cells. So there are a few studies which gave GCSF in case of ACLF, and both of these, there were two studies, and both of these showed that survival was higher in patients who received GCSF in comparison to those who received just standard medical therapy. So another hypothesis is that bacterial translocation is a very important contributing factor for ACLF. So a study showed that a study on patients who were of alcoholic hepatitis were ineligible for corticosteroid. They gave FMT, and then it showed better results in comparison to those who didn't receive FMT. So liver transplantation should be considered to those patients who have baseline MALE of more than 28, ARC score more than 10, 11 or more, because the 28-day or 90-day mortality is very high in a patient who has ARC score of more than 10. So advanced HE, that is grade 3 or 4 HE. So these patients we should consider for a very early liver transplantation. So the overall survival of 1 year survival of liver transplantation was very good in a meta-analysis. Approximately around 85%, 85 to 90% of 1 year survival, those who underwent liver transplantation in case of ACLF. So the management of algorithm of patient with ACLF according to the ARC score. So whenever the ARC score is less than equal to 10, we go for a standard medical treatment, and then at day 4, if the ARC score decreases by more than 2 and if there is no organ failure, go with the standard medical treatment and regenerative therapy. But if the ARC score doesn't decrease by more than 2 up to day 7, then we should go for liver transplantation. But if the patient has organ failure of more than ARC score of more than 11, or the patient has non-hepatic organ failure or just single organ failure, go for liver transplantation. But if the ARC score is more than 11 and then there is more than equal to 2 organ failures, we go for organ support. And at day 7, if the score doesn't decreases by more than 2, go for liver transplantation. If not, then supportive therapy. There is no rule of liver transplantation if the score doesn't decrease by more than equal to 2 at day 7. So this is the primary management according to the ARC score that was developed by Asian Pacific Association for the Study of Liver. So hepatocyte transplantation can be done. So there is not much study regarding hepatocyte transplantation, but it has shown that if the patient tolerates hepatocyte transplantation, then the survival is better. So stem cell transplantation, there is a study that's going on, DELIVER trial. So it's a phase 2 trial which is going on regarding stem cell transplantation in case of ACLF. So finally, there is a last slide saying that is there any way we can prevent ACLF? So yes, obviously we can reduce the incidence of ACLF by avoiding infections, especially nosocomial, proper use of albumin while doing large volume paracentesis, judicious use of antibiotic prophylaxis, primary prophylaxis for variceal bleeding, avoid hepatotoxins, especially herbs, drug minimization, use of PPI avoidance as outpatient, and then good compliance with drug therapy. That is, if the patient has autoimmune B or Wilson's. Thank you.
Thank you all the speaker, Dr. Nandu Paudel, Dr. Bisal Kesi, and Dr. Pukar Thapa for giving the wonderful presentation. Now coming to the question and answer. Are there any questions from the floor? If there are no any, I would like to ask. I would like like to ask one question to Pukar Thapa. You have mentioned giving steroids in severe alcoholic hepatitis, but we are in our day-to-day clinical practice, we are afraid to give steroid in severe alcoholic hepatitis. What are your experience regarding the use of steroids?
Actually, using steroid in severe alcoholic hepatitis is a very good thing, because we should differentiate. We should categorize the patient first. Is the patient has chronic liver cirrhosis or not? And then if the alcoholic hepatitis is occurring in a previously chronic liver disease or not. First we should categorize these patients into two groups. And another is that the patient there is any contraindication of steroids, like the patients have already overt sepsis, or something like the patient has uncontrolled diabetes. Maybe in those cases it's not safe to use steroids, but otherwise using steroids in severe alcoholic hepatitis decreases bilirubin level, especially the bilirubin level, and obviously it decreases the mortality and morbidity regarding steroids, alcoholic hepatitis. So we should not be so much afraid using steroids in alcoholic hepatitis, providing that there is no contraindication to steroids.
Thank you.